Giovanni. And before we go into the crux of the presentation, I have a few slides that I would like to share and to give you some background on not only the Fiscal Health from Systems to Sustainability initiative, but how we will be conducting the webinar today. This slide shows the toll-free dial-in information and the event number access code should you get disconnected at any point during the webinar. Just to let you know as well, we are recording the webinar and it will be archived within the next 2 days and available for those who maybe have joined us later or have missed it or would like to review this or provide it as a resource for their colleagues. During the webinar, we will be accepting questions in the Q&A box that you see to the right of the slide on your screen. We ask that you, any question that you have, that you provide it to us in that Q&A box, understanding, of course, that your question may be answered at some point during the presentation. But if it is not, we will share that with the presenter in the time allotted at the end of the presentation for question and answer. Briefly, the Fiscal Health Systems from Sustainability program is designed to ensure that the fiscal sustainability of Ryan White-funded grantees. We have 3 modes of doing this: through regional trainings that happen on-site in a region across the country, and as well as through individualized technical assistance where you can request through us, and our online learning platforms, including the webinar series that you're taking in part today. This program is sponsored by HRSA-HAB and is administered through Health HIV. Specifically, this program was designed for Part A and Part B subgrantees, Part C Early Intervention Services grantees and subgrantees, and Part D grantees and subgrantees. If you go to our website, www.healthhiv.org, you will see a number of fiscal health-related resources on our Fiscal Health from Systems to Sustainability Resource Center page. Also, this page affords you the opportunity, should you have the need or request for additional technical assistance, to do so. We have an upcoming webinar next Tuesday on effective health insurance eligibility determination strategies. For additional information on that webinar or additional questions about the Fiscal Health program or any other related to the webinar today, feel free to contact me directly at my email address that is provided for you. Really quickly today, I wanted to provide a little bit of background for our presenter, Bob Bongiovanni. He has almost 20 years professional experience working with the Colorado Department of Public Health and Environment. And in his time there, he has managed multi-million-dollar budgets for healthcare and prevention systems, as well as assessing provider capacity, designing initiatives, enlisting departmental community support, conducting training, and implementing requests for proposal processes. He has a great wealth of knowledge on the HRSA fiscal monitoring standards. So I will go ahead and turn the presentation over to Bob.
Hello, everyone. I'm very happy to be with you today, and I am looking forward to this conversation with you. I'm going to be trying to cover quite a lot of material. The fiscal monitoring standards themselves, as published by HRSA, are 46 pages or 40-some pages, depending on Part A or Part B. So obviously, I'm not even going to be able to go into great depth just on those. I'm also going to be bringing in hundreds of pages of other kinds of standards and trying to digest them down to a 1-hour conversation. So I'm going to be going through this at a pretty high level of abstraction. If you do have a more detailed question and it's within the scope of this conversation, I'd be happy to answer it. As Julio said, just type your questions into the Q&A box and we will get to those. I'm going to be talking to so many different audiences here. I'm trying to tailor the talk to a wide variety of circumstances. If you are a Part B or Part A grantee, this is going to be directly related to what you do as you put together your application, design monitoring systems, and design all the ways in which you comply with HRSA expectations. If you're a sub-grantee, this will give you a window into the overall requirements and why certain things appear in your contracts the way they do, and why you're monitored in some of the ways that you are, and give you a sense of how you may need to prepare for your site visits and for audits and all the other sorts of processes we go through as part of our role as Ryan White funded providers or grantees. So, let's proceed. So today's agenda, we're going to be talking about some limits on specific types of costs. We're going to be talking about unallowable costs. We're also going to be talking about income from fees for service providers, which often goes by the title program income. We'll be talking about client charges, specifically limitations on client charges. We're going to be talking about some audit and accounting guidelines, not in a great deal of depth, but we will be talking about them, as well as match and maintenance of effort requirements, since those also appear in the fiscal monitoring standards. We'll be talking briefly also about rebate balances and unobligated balances and rebates. And then I'm going to touch on the new OMB super, what they call the super circular, because it's going to be rolling out and it's going to have a big impact not only on the fiscal monitoring standards as they're written by HRSA, but the ways we do business in so many different things, from procurement all the way through site monitoring and closeout of grants. So a lot of territory to cover today. Let's talk about limits on administrative planning, evaluation, and quality improvement costs. So this is clarified in PCN 1501. When I refer to policy clarification notices or other materials, if you want to look at those, go to hab.hrsa.gov and go to grantee basics or policy notices, and you could read them. The basics of this part on the limitations is administrative costs cannot exceed 10% of the award, and planning and evaluation costs also cannot exceed 10% of the award. So as you're putting together your budget, you have to stay under those limits. And then there's the rule that we in Colorado affectionately call the 10 plus 10 equals 15 rule, which says that if you total those two, the total of them cannot exceed 15%. All right? And then your quality assurance costs or improvement costs are limited to an additional 5%. So let's talk a little bit about that by going through some more detail. Policy Clarification Notice 1501 came out recently. It was welcomed by many grantees because it provides more flexibility around administrative costs than it had existed in the past. There were some costs that were previously considered to be administrative that can now be charged to relevant service categories, and since, as we just said, those have caps on them, it's very nice to be able to move some things into service categories. So what are some examples of things that used to be considered administrative that now under this new PCN can actually be considered direct costs? Things like rent on areas that are utilized for service delivery, the costs that you may incur staff-wise or other for recertifying clients, the cost for your emergency or your medical record, your electronic medical record, as it relates to Ryan White funded services. Maybe you have staff that set appointments or do follow-up on appointments that used to consider administrative. They can now be considered direct service. Medical billing costs as they relate to Ryan White funded services. If you have supervisors that are supervising people doing Ryan White funded services and doing sort of quality assurance on those services, those can now be considered direct costs. And then your own, if you're the grantee, your indirect can actually be now spread out over your service categories. That is not something that is available to a subrecipient or a sub-grantee at this point. That probably won't be. Those continue to be subject to the administrative limit. As a general rule of thumb, whatever you do that you're trying to say is not administrative, you really need to relate it back to the delivery of a Ryan White funded service. If it doesn't relate back, it's probably still considered administrative. So, for instance, if you just have your executive director going out and doing marketing of your programs in general, that's still administrative because you really can't relate it back to the delivery of a Ryan White funded service. On the other hand, if you have a supervisor that's looking over case management records, to make sure that those case management services match your standards of care. That is relating back to a specific service that's experienced by a specific client, and that can actually be considered a case management expense. So this is a big change. I know many jurisdictions and grantees and sub-grantees around the state or around the country are reviewing their budgets right now to take maximum advantage of this flexibility, and you're well advised to talk to your project officer about your efforts in that area if you have questions. So I'm going to go over a couple of examples here. The ones with the red lines through them will not go, but the one with the big green thumb is all right. So for instance, suppose you put together your budget and you wanted to put 12% of your budget to administrative costs, 6% to planning and evaluation, and 4% to quality improvement. You can't go over 10% on either administrative or planning or evaluation. Plus, if you add those together, those are over 15%, they are 18%, and you got more than 3% in your quality improvement's okay. But that budget would not work. Suppose you were proposing to put 9% into administrative and 5% into planning evaluation. That's so far so good. Those are both under 10%. They add up to less than 15. Oops, 8% higher than 5%. So that second example won't work either. But this next one, this is pretty much the maxing out. 8 plus 7 equals 15 plus 5 equals 20. You're fine. You're not exceeding the limits. There's one caveat on that last one. If you're a large jurisdiction and the quality improvement would be over $3 million, you can't exceed $3 million in quality improvement either. But for most jurisdictions to get less than that much, than $60 million or so, this last budget would work just fine. Just a quick overview of that. Let's talk about if you're a grantee and you have subrecipients, which I'm sure all of us do. The limit there is that the aggregate subrecipient administrative costs are limited to 10% of the total services dollars awarded to subrecipients, all right? So that doesn't mean that individual ones have to be under 10%, but it means that if you aggregate all of your subrecipient administrative costs together, they cannot exceed 10% of the total service dollars awarded to your subrecipients. And what do we mean by subrecipients administrative costs? Like usual and recognized overhead activities, management oversight, other program support, or other indirect costs charged by subrecipients. If it's a subrecipient, they cannot be charged out to the individual subcategories if you're calling them indirect. If they're calling them indirect, they should also be evidenced by an approved HHS indirect cost approval. So I know I'm moving through this pretty quickly, but I'm just trying to give you an overview of some of these more straightforward things. 25% limit on support service costs. This has been in effect for quite a long time. We're all familiar with this. As you're putting together your budget for how you're going to be utilizing your dollars, and you're giving evidence to HHS on how you did use your dollars, you have to be very careful that no more than 25% of your service dollars are expended for what they call support services. And if you have any question about what those are, again, I would send you back to hab.hrsa.gov for a listing of which HRSA-defined service categories are considered support. That means that no less than 75% of your service dollars must be expended for core services, all right? They will define what those are. You may request a waiver in advance, which I'm going to talk about in a moment. And with the rollout of the Affordable Care Act and health care reform in a lot of states, many states and jurisdictions are finding themselves in a position of not needing as many service dollars for core services and having an increased need for service dollars for support. So luckily within the law, there is a provision for getting a waiver for that. That's PN 1307. That waiver request has to be submitted anytime before your application every year or up to 4 months after the start of the grant year. And as part of that process, you're going to have to well document a certain set of conditions. For instance, you have to get a written assurance from your ADAP director that there's no current or anticipated ADAP waiting list. All core medical services are must be available within 30 days for people who need them. So what they're trying to avoid here is that you're shorting the core services and then people are waiting in long waiting lists for inadequate services funded by other other sources. You need to document a public process having taken place that supports this idea of a waiver of the 25% limit. And then there's a pretty extensive narrative explanation that you're going to have to submit, and I would refer you again to hab.hrsa.gov to read Policy Notice 1307 that goes into significant detail on what you need to put into your narrative. So one of the processes I did in order to prepare for today was to go through the entire fiscal monitoring standards, as well as all the program monitoring standards for Part A and for Part B, and the universal standards and anywhere else I could think of in the manuals where they list unallowable costs. This is a big part of your job as fiscal monitors or as program monitors for that matter, to make sure that as you're signing off on those reimbursement statements or invoices or whatever you call them at your state, that there is not something slipping through that HRSA has very clearly said is an unallowable use of Ryan White funds. I'm not going to go over all these. I'm just going to touch on a few of them. They're probably the ones you're going to run into more often. Hopefully you don't get a lot of requests for pet food, but, you know, perhaps. But what usually ends up happening is, has someone made a cash payment to a service recipient? That's a very big no-no. It is often quite tempting to grantees and sub-grantees to do that because of the disparate situations they find their clients in, but it is absolutely prohibited. They have a very interesting definition of this where they say if it's a gift card that has an expiration date, that is not considered a cash payment. Then you're going to have to make sure that you log those very carefully in an auditable manner. But anything like a check or currency absolutely cannot go to a service recipient. Medical or other care provided in a hospital, emergency room, or other inpatient basis. Again, this one can be kind of tricky to detect, but it is quite clearly prohibited in the legislation and in all of the guidances subsequent. Just going to hit on a couple of other of these. Any kind of foreign travel, mortgage payments. One of the trends that you'll kind of see in here is if you're actually contributing, giving something to a client that's increasing the value of their asset, then that is generally prohibited. So paying a mortgage, which ultimately results in them owning a house, is prohibited. You'll also see things in here about paying a client's car payment, for instance. Those purchase of vehicles have to get grants management officer approval. So anytime you're buying an asset for a client, you're probably getting into dangerous territory. You cannot purchase pre-exposure prophylaxis for an HIV negative person using this. You have to be quite careful about your marketing programs to make sure they're not just sort of general purpose marketing, but are really getting at some very specifics around Ryan White services. Also be quite careful about your outreach activities you might be funding to make sure they're not just for the purposes of HIV prevention or HIV education. Obviously we can't lobby, can't pay for criminal defense unless it's related to a service eligible for Ryan White funding, or class action suit I should say. Can't contribute to the creation of a liability risk pool, and you can't use this money to carry out a program to distribute sterile needles or syringes for hypodermic injection of illegal drugs, and you cannot use it to develop materials designed to promote or encourage intravenous drug use or sexual activity, whether homosexual or heterosexual. These are things that are written into the overall PHS law and cited pretty extensively throughout. So about all you can do on these is memorize them and put them into checklists and make sure that everyone on your staff is well aware of them, and when you do your site visits and you do your sampling, that you have active and documentable ways to detect any of the above. Let's talk about program income, or income from fees for services provided. So here's a definition from 45 CFR 92.25, which is a federal regulation. Program income is gross income received by the grantee or subgrantee directly generated by a grant-supported activity or earned only as a result of the grant agreement during the grant period, right? There's some very clear examples of this, and then it starts to get into some grayer territory that you're going to want to have conversations with your program officer about. But probably the clearest example would be you fund a HIV clinic to provide HIV care. You are the predominant funder of that clinic. If your funding went away, that clinic would cease to exist, and that clinic did not exist before you came there. If that clinic is now charging certain amounts to clients for co-payments or co-insurance, if they are charging any kind of fees whatsoever, if they're actually billing for services to a patient's Medicaid or private insurance plan, all the money that that clinic is receiving from all of those sources is considered program income because it was directly generated by a grant-supported activity, right? So that activity, that clinic would not exist without the support of your grant. Therefore, all of the income it receives over and above your grant to them is going to be considered program income. And once you call it program income, it has some specific requirements. So, as I mentioned, things like Medicaid, Medicare, other third-party payers, and charges imposed on clients are the two most common forms of program income. Once you've identified that one of your, either you as a grantee or a sub-grantee are doing this, or someone that works with you is doing this, you must insist and you must put in their contract that they are required to report their program income in aggregate, not at the client level, in the FFR and in the annual data report. And then that sub-grantee has program income. You must contract with them and insist that they track it and report it to you as the grantee. Why this is particularly important is described on the next slide. Sometimes, particularly in large organizations, there's a great temptation to take money that might be generated from program income and divert it into the larger coffers of the organization, right, to cover some other clinic that's not doing as well, or to cover some other kind of cost that really is only tangential, if not completely unrelated to the activity of your HIV program. That is specifically prohibited. That larger entity cannot divert that money to anything else. It must be retained by that funded program and used for program purposes. And you, if you're the grantee, you're the one who's putting out that contract, it is incumbent upon you to make sure that that is being complied with, that you know that your awardees are monitoring their program income and that they are using it legitimately for something that advances that program. It is not subject to the 25% limit or 75% limit. They could be using it to enhance their electronic data systems. They could be using it to improve their quality. They could be doing a lot of different things with it. It's not that you're going to micromanage necessarily exactly what they use with it, but you certainly don't want to come in and find out that it's being used to pave the roads, you know, across town. It's been diverted into a completely different activity. That is when you have problems. I don't know why I'm hearing music now. Okay, let's move on. Great, someone might have put us on hold. So moving on, payer of last resort. Interestingly enough, the word payer of last resort doesn't actually even exist in the legislation. What the legislation itself actually says is that Ryan White funds may not be used when payment has been made or can reasonably be expected to be made under any state compensation program, under an insurance policy, or under any federal or state health benefits program. And there are exceptions carved out for Indian Health Services and for the Veterans Administration. So this is saying that if you have an activity that could potentially be funded by a client's insurance policy, by their Medicaid coverage, by their Medicare coverage, those types of sources, you may not use your Ryan White money to pay for those things. This gets into some very tough territory, both for us as grantees and sub-grantees, because we know there could be deficiencies in what those programs will cover. And this comes down to your discretion and to your consultation with your own staff and with your program officer to clarify what that word reasonably means. That becomes very important. So let's talk about client charges. If you are a provider that charges anything to any client, you are responsible for making sure that that client, the amount that that client is charged is under the limitations that are literally written into the law. So these are not negotiable. If a client is making less than 100% of the federal poverty poverty level, you must not charge them anything for the services, for the Ryan White services, all right? So this is quite difficult, I understand, in large organizations where they have a policy that we have a $10 copayment for everything that comes through our clinic. Every client gets charged that. They just must pay it. If you're taking a Ryan White grant, you have agreed to waive that for all of your clients that have whose annual income is less than 100% of federal poverty level. This is a very common deficiency found in audits and in site visits. People just often apply the larger fee schedules they have, the sliding fee schedules they have for the clinics. That I have seen 2 clinics in my own state be written up for this, so I know that this happens. We have to make sure that that gets taken care of, that you are auditing that properly, and that you are making sure that it's following the requirements. If a client is between 100 and 200% of federal poverty level, you cannot charge more than 5% of their annual income. If it's between 200 and 300%, it's 7%, and more than 300%, no more than 10%, right? Notice that this is client annual income. This is not household poverty level. So this goes down to individual client level income. This can be also very challenging. These limits are across providers. So suppose you have a client that went to 3 different Ryan White providers, and the first one charged them $1,000, and the second one charged them $500, and they're at 10%. The third clinic cannot charge them a penny. They have reached their annual limit. It is incumbent upon the client to document that situation. So the client would have to come to Clinic 3 with receipts and with proof that they've hit their 10% limit and that they should no longer be charged anything. This is quite challenging for clients, case managers, and everyone else. Your main responsibility within your own clinic is to make sure at least you aren't trying to charge them more than 10%, right? So you need to know what their annual income is, and you need to know when you have charged them under this fee schedule up to 10% or 7% or 5% and stop charging them. Again, this is a very common mistake that grantees make and sub-grantees make, often the subject of audits and other problems. There we go. A few other requirements around that limitation on charges. Providers must publicly post their schedule of charges. So this cannot be a secret to anyone. There has to be a process where clients can know what it is in advance before as they receive your services. And certainly if you make any changes to it, you must publicly post the changes. Here's an interesting one that is often missed. If a provider charges any fees to any client, they must impose a fee for clients over 100% of federal poverty level, right? So you do not have the flexibility at the local level of saying, well, we're not going to charge anything to people until they hit 300% of poverty. No, you must, if you're charging any fees to any client, you must impose some kind of a fee for a client over 100% of poverty. It's just the way the federal law was written. So that could be nominal. So you could say for clients between 200 and 300% of poverty, we charge $1, right? That would be permitted. But you can't say we waive it entirely. All of this, if you're the grantee, must be monitored for your sub-grantees.
Good grief.
All right. Let's get into some accounting and audit guidelines now. This applies to both you as a grantee or you as a sub-grantee. As we've already heard, there's a lot of regulations that surround this money, a lot of limits, a lot of requirements, unallowable costs. You have to have a fairly sophisticated system to track all of that, to have the types of internal controls that will make sure that those are rare events that are detected and prevented. You have to demonstrate that your fiscal management system adheres to all the things I just covered, as well as many of the other things that we're not going to get to today. That includes all of your systems, your policies, your budgets, your procedures, your reports, and your records, all in compliance with accounting and audit guidelines set by HHS and by HRSA. Some of the more problematic areas of this have to do with allocations. Do you have a sophisticated enough accounting system that you can allocate a person's time, your staff's time, all of your expenses across all of those service categories and do that in a reasonable, justifiable, and auditable manner. That can be quite challenging. There are, I believe, last time I counted, there were 23 fundable service categories under HRSA, which means you have to have an accounting system that is sophisticated enough to budget, to take every dollar that you spend and spread it either to administrative, planning and evaluation, quality improvement, or one of those 23 service categories. That can be quite challenging. Challenging for states, I will say, but as you are working with smaller organizations in particular, that takes a pretty dynamic accounting software and policy and a pretty sophisticated way of handling their accounts. As you're developing your budgets, you will see a constant requirement for things to fall into administrative, planning, evaluation, clinic quality management, HIV services, and if you're an ADAP, if you're a Part B, ADAP, and then Minority AIDS Initiative. They expect to see all of your budgets come down to those categories. And if you're a subgrantee, you realize why your grantee is constantly forcing you to put things into those categories as well now. We're having a little delay in moving some of these slides forward. I apologize for that. If you have budget modifications during the year, if they are relatively small, you can do those, but you must keep track of them because if in a cumulative manner they amount to 25% of the total approved budget or $250,000, whichever is less, you really need to get those pre-approved by HRSA. This is really easy to lose track of, particularly if you're giving out some large awards or, for that matter, many moderately sized awards. That suddenly you realize, oh, I told them I was going to spend $500,000 on case management, and it actually turns out I'm going to spend $790,000 on case management. Well, I just transferred more than $250,000, and I really should have gotten that approved by HRSA. There's also this more nebulously stated, if the rebudgeting involves a change in scope. I would suggest that you talk to your program officer about what that would mean to them. Does that mean changing from a support service to a core service? Does that mean moving something into administrative that was a direct service? Probably, but there's some others that aren't necessarily a dramatic change in scope, and you probably want to just have a frank conversation with your program officer when it looks like you're going to be rebudgeting something like that. Another commonly missed mistake that gets picked up in audits and in site visits, if you ended up purchasing a unit of equipment exceeding $25,000 and you didn't actually state that in your budget, that is a problem, because anytime you are going to rebudget and purchase a unit of equipment that would cost more than $25,000, that is supposed to be purchased, that is supposed to be pre-approved by HRSA as well. Here's where it starts to be interesting, particularly for your accounting and your contracting staff. As you're developing your sub-grantee agreements, you need to be very careful to include all the necessary provisions that allow you to enforce all of these things that we've been discussing today, as well as many others. You need to come up with a contract language around things like program income, around payer of last resort, and that needs to be in your contracts. I'm going to switch over for a second to a tab, which I believe all of you can see as well. It's called Sample Contract Language. So what I've done here is put together a couple of pages of sample contract language around payer of last resort and around program income that I think you might just take a look at. In no means am I giving you guys legal advice. Your own contract attorneys and contract staff might look at these provisions and not particularly care for the way they're worded, but this is just to give you a sense of how you might take the language from all of these regulations, these policy notices, and so on, and put them into the contract of your subgrantees, because as we all know, if it's not in a contract, you can't enforce it. So if you have a contractor that's been collecting massive amounts of program income, and you have nothing in your contract that says they were supposed to be reporting that to you, you don't have much of a leg to stand on to make them start doing it, or to compel them, I should say, to start doing it. And if you get audited and fail that, they're going to find both you and your subrecipient in violation of these federal rules. So I've just given that, and that's downloadable. You should be able to take those and peruse them at your leisure. You also need to make sure that if you acquire a unit of property costing $5,000 or more, that you track it and you report it, and that make sure that your language in your contract gives HRSA reversionary interest. What that means is HRSA reserves the right that if that contract ends, that they can confiscate that computer, that air conditioning unit, well, they probably didn't buy that, but whatever it is that you purchased for $5,000 or more, they reserve the right to retain that and direct you to send it to them or to someone else. In Colorado, we often put that in our contracts that say that the state has a reversionary interest, and then we would then in turn offer that back to HRSA. So we act as an intermediary on that. But if you're a grantee and you've seen that in there before, now you know why. HRSA retains reversionary interest on those. Probably important to inventory those properly. So I've seen people say, oh, that's a $5,000 computer. Well, it's not actually a $5,000 computer. What it is a $1,300 CPU, $2,000 worth of software, and a $500 printer, right? It's a unit of property worth $5,000 or more, non-separable into those parts. Any questions about that? I would strongly urge you to chat with your program officer about what they interpret that to mean. Here's another one that's often missed, and I know can be quite challenging. If you are a contractor, you should expect to get paid within 30 days if you turn in an accurate and complete reimbursement. If you are a grantee, you should be prepared to pay someone within 30 days if they turn in an accurate and complete invoice. That's actually written into the federal regulations. So if it is later than that, technically your sub-grantees have a bone to pick with you, which they could get a sympathetic hearing with HRSA on. Let's talk for a moment about cost principles. As you look at the regulations, you'll see that HRSA is quite concerned about arrangements where you are paying a contractor to do something where the costs that they are claiming are quite out of line, that they would not be reasonable compared to prevailing pricing. You're paying vastly more per hour for a person's staff time. You're paying vastly more for a unit of case management than what is seen around other places in the country or even within your jurisdiction. HRSA is quite concerned about this. They state within the fiscal monitoring standards that these must be cost-based, meaning they must bear some reasonable resemblance to the actual cost of delivering the service. That can be a little tricky to get to, particularly with hospitals, but that's what it's supposed to be. And that you, as a grantee and as a subgrantee, should be monitoring to make sure that you're not getting quite out of sync with what the prevailing pricing is for a similar service. Unit costs should be calculated, meaning you should take the cost of delivering that service and divide it by the number of units and finding out what the unit cost is. And you should be doing sufficient sampling and inquiry to make sure that that is not exceeding the actual cost of delivering the service, right? There's some specific rules for AIDS drug assistance programs. If you're purchasing medications, that cannot exceed the 340B pricing plus a reasonable fee for processing and claims and so on. And as an ADOP, you are responsible for pursuing the best pricing available with all available drug rebates. When it comes to cost of health insurance assistance, again, this applies to Part B and ADAPs. The cost of acquiring health insurance and helping a client with that health insurance in aggregate cannot exceed the cost of providing the medications directly to that client, right? So that means that on an ongoing basis, you keep a rolling kind of aggregate cost that it costs you if the client is uninsured and you're just providing those medications directly to the client versus the cost per client of purchasing their health insurance and covering their co-payments and their co-insurance. In aggregate, again, this is often a confusing point for some people. If you have 10% of your clients that are costing you $12,000 for their health insurance related costs, but 90% of them are only costing you $5,000, and the cost of doing buying medications directly is $10,000, you're okay, because it's in aggregate. So you can make a few exceptions and allow some individual clients to exceed the cost that it would be of buying the medications directly, so long as when you put all of your clients together, the costs are not greater than just providing the medications to those clients directly. Hopefully that makes some sense. I know some states apply that down to the individual client level, and that is actually safe, but probably overly restrictive. Let's talk about auditing. And this is where the new super circular I'm going to talk about is starting to come into play. If you have subgrantee, or you are a subgrantee that receives more than $750,000 in aggregate federal funding, you must have an A-133 audit. That used to be $500,000. As states are now implementing the super circular and more federal agencies are implementing this new set of regulations, you're seeing it all go up to $750,000. If you aren't there now, you probably will be the next time you renew your subgrantee awards. If there is a reportable condition, so something goes wrong or there's something, an error detected during that A-133 audit, and you must convey those to HRSA along with a resolution plan, right? So that could be your A-133 audit as the Ryan White program, or it could be an A-133 audit that was done on one of your subgrantees. If there was something that was significant enough to be considered a reportable condition, then you need to, don't wait for HRSA to find that on your own. It is your responsibility to inform them of that. Also, if you're a Part B program, you have a requirement. They're supposed to be collecting all the A-133 audits of your subgrantees and submitting them to HRSA every 2 years. That may not be happening by your program. There may be somebody else, maybe your internal auditor or other fiscal staff that are doing that, and you just don't know about it. But if you're the program manager or director, you probably want to make sure that that's happening by inquiring who is collecting those and who is submitting them. Just a couple words here on match and maintenance of effort. If you're subject to match, you probably know it. It's written right into your Notice of Grant Award. There's a formula. It has to do with the percentage of the national epidemic that you represent. So if you're subject to it, you probably know it. If you don't, go read your Notice of Grant Award and you'll know whether you're subject to match or not. Your Notice of Grant Award will also tell you the ratio of the match that's required. So, for instance, it could be $1, you need to come up with $1 of non-federal funding that's being spent for every $4 of federal funding you're receiving. This is a difficult task, but again, very important, often the subject of site visits and audits. Make sure that some other program isn't already using that same dollar to match, right? So if you're using some portion of your Medicaid or one of your county health departments is matching your grant at the local level, just make sure that that's not also matching 5 other awards from 6 other federal agencies, because that's a big no-no. You need to verify that there's only one match. Talk about maintenance of effort. Probably years ago, your health department or you as a grantee established a certain amount that you agreed to as a maintenance of effort, meaning you would continue to supply that amount of support for your program for as long as you're receiving the federal award. That just needs to be maintained equal to the level in the year preceding the current year. So you'll often see, so this is 2015, you have to show your maintenance of effort for 2013 funding, right? Also be careful here, you have to maintain that level, and you can't be claiming money that's also being claimed by a bunch of other different programs, and you have to make sure that you keep up on that, all right? You must not use Ryan White funding to supplant state or local funding, and what they talk about is having a consistent, rational methodology for doing this. So most jurisdictions that have this maintenance effort requirement will say, okay, we're always going to use a portion of our general fund dollars for our ADAP program to be our maintenance of effort, and we will keep that consistent from year to year. It's generally inadvisable to say, well, this year we're going to use the general fund for the ADAP program, and next year we're going to use the money we got from Medicaid, and the year after, and then maybe we'll use something from our Drug and Alcohol Authority after that. You have to have a consistent, rational way of approaching this. It's usually advisable to stay consistent from year to year in what you're using for your maintenance of effort. Unobligated balances. This has been a big controversy for quite a long time, and HRSA has issued a lot of very helpful clarifications on how you handle this, around the penalties for it, and how you depict this on your FFR to avoid getting into problems. The essential message here is that HRSA expects its grantees to efficiently expend 95% of its awards in any grant year. If you're a sub-grantee, now you know why your grantee is often very nervous in the last quarter of the year when it looks like you aren't spending down your award, because that could put them over 5% in total. If you have up to 5%, you can report that, and then there's a process for requesting it as a carryover into following years, and there are no penalties involved. It's when you start creeping over 5% that it starts to be a problem. And there are some significant penalties for having excessive unobligated balances: offset, reduction of awards, ineligibility for supplemental awards. This is something that most places try to avoid if they can. Rebates complicates this quite a bit. This is usually applicable to Part Bs and ADAPs. The rebate monies must be applied to the program, and the priority is that it be used something related to the AIDS Drug Assistance Program. That's not a requirement, but that's a strong desire on the part of HRSA that be set as the priority. You must expend your rebate funds before you draw down your grant funds. So it's really supposed to be paid out of those first. You don't want to be ending your fiscal year with a bunch of unexpended rebate funds and all of your federal funds expended. That would be problematic. Now, here's where it complicates your unobligated balance. If you complied and spent your rebate funds first, and that resulted in a higher unobligated balance of your federal funds, you are allowed to reduce your unobligated balance by the amount of your obligated rebate funds. So they're basically saying if federal regulations are forcing you to spend your rebate funds first and you're complying appropriately, you will not be penalized because you have excessive unobligated balances of your federal funds. So you will disclose your rebates if you're a Part B ADAP kind of a program, you will disclose those on your FFR on line 12. In no circumstance should you be showing your rebates as program income. This was a real serious issue with states a few years ago. I think HRSA has done a lot to fix that, to make sure that states treat these funds in this very special way. They are not federal award. They are not program income. They are only something that you put on a comment line in your FFR. And if you have a doubt about that, you should probably check in with the folks in your department that do your FFR and make sure that that's being handled properly on line 12. Somebody probably would have told you about it by now. They've been pretty good about detecting that. Let's just take a couple minutes before we go into questions about this new Office Management and Budget Super Circular. That's the euphemistic name for it. It's actually 2 CFR Chapter 1 and Chapter 2, Parts 200, 215, 220, 225, and 230. Super Circular is a lot easier to say. It became effective as of December 26, 2014. It augments and supersedes what we used to call A133, A21, A87, A201, A110, and A122. So it was meant to streamline all these other circulars into a single kind of omni-circular, along with strengthening oversight and putting the focus more on improving outcomes from these awards rather than just counting numbers. it absolutely will impact your fiscal monitoring practice. So if you go to tab.hrsa.gov and you look at the fiscal monitoring standards, which I'm sure you do and should, you will see this very interesting little box has appeared on there that says that some of the things in the fiscal monitoring standards are going to be changing because of this new super circular, and that states should be preparing themselves. Chances are very good, if you're within a state health department, that either your controller's office or your department controller's office is well aware of this, because this does not apply only to your HRSA HAB funding. This applies to all federal awards. So if you have any federal money coming to your state or your jurisdiction at all, they are having to grapple with changing all of those contracts and changing many, many, many different processes to comply with this new OB super circular. I'm just going to talk about a couple of those. These kind of digest the most critical changes. There are many different changes now around cost principles. The ways that you handle indirect, your time and effort reporting, your treatment of specific assets and costs are changing from what they were previously. So contracts are changing around those specific areas especially. There are also some administrative processes that if you're either the subject of a monitoring visit or you conduct monitoring, you're seeing more conversations about things like risk reviews. The promptness of funding announcements is now covered under here, which I think is quite fascinating, that the federal government is supposed to be giving entities longer to comply or to apply for funding than has been the rule in the past. Many different conversations about how you cost out property. We're all going to have to learn this language called contractor versus subrecipient, right? Because that is actually explicitly within the super circular. I put contractor in quotation marks because it is so unfortunate they chose to use that term. A subrecipient is someone, for instance, that you delegate a lot of your eligibility testing to. They're really doing things on your behalf, but they are getting an award to do the work that they do and to do the eligibility testing and to follow your standards of care. Many, if not the vast majority of our contracts fall under this new category called subrecipient. If you're like buying medications from a drug wholesaler, that's an example of a contract. Why I put this in quotation marks is you can have contracts with subrecipients. So you just kind of have to get your brain around this, that within the OMB circular, when they talk about a subrecipient, they're talking about pretty much an entity that operates more autonomously from you and is doing things and enforcing your rules on your behalf, versus others that are really just providing you with a service that, or you're purchasing something from that is more straightforward. They don't do any eligibility checking, and there's other criteria for this. Your controller's office and other people higher up in your fiscal structure will probably be coming out with checklists, I know ours did, that will distinguish between is this a contractor or a subrecipient. So just don't be surprised when you see that, and if you're a subgrantee, don't be surprised if you've got a lot of questions along that. Auditing, the good news is that the A133 threshold is rising. The less good news is that they are much more likely to be, the findings of those are much more systematically reported to the federal grantee, and really they said at one point that they were going to simplify the A133 audit and focus it more on fraud and outcome, but that has yet to happen. So A133 audits are as complicated as they ever have been. However, not as many entities are required to have them. So that leaves us with about 33 minutes for questions. Julio, do I turn this back over to you at this point, or what should we do from here?
Yes, thank you. First of all, thank you, Bob, for really distilling that information for us in an hour in a very precise way. I have several questions that folks have been typing in over the course, but I'd like to address quickly a quick housekeeping item for those that are listening, as I know that several joined a little bit later and may have missed the beginning. We are recording this, and we will archive the webinar as well as the materials associated with the webinar on the Fiscal Health resource page of the Health HIV website. So for those of you that may have missed anything, it will be available to you within the next week. Really quickly, moving into the first question that we received, I wanted to turn it over to Bob really quick. The question is, does the 10% on planning evaluation apply to Part A with a 15% cap on administrative and planning/evaluation?
So that rule actually applies across all parts. So you really can only spend 10%, a maximum of 10% each on your planning and evaluation as one category, and your and then 10% for the other category. Together they can't exceed 15%, but those rules are not different for Part A or Part B, or as far as I know. I also saw a question that said, does this only apply in California? No, this applies to all grantees that are receiving Ryan White funds. Hopefully that answers that question. Yeah.
Thank you. The second question is, I have a medical provider that has requested funding or registration payment for the International HIV Conference in South Africa in 2016. Will we be able to pay for her registration if the conference is in another country? I saw that we couldn't use funds for foreign travel. Thank you.
In my opinion, a registration fee for an event in a foreign location is considered a component of foreign travel, and you should not be using Ryan White funds to pay for that. If you have questions about that, I would ask your program officer, but I know as a person here in Colorado, I would have disallowed that cost.
Okay. The next question is, if a client is being seen by a clinical care provider who only serves Part B clients, is the provider required to charge clients above 100% of the federal poverty level? If the provider serves both Part B and private pay clients and charges private pay clients based on a sliding fee scale, then must Part B clients above 100% federal poverty level be charged?
So this is where it starts to get into some pretty complicated territory when you have contractors that are getting funded by multiple parts. And there's actually, the HRSA policy notice actually goes into some detail around this, but I will say this. It applies to the clinic in its entirety, all right? Now, if you're saying a part of that is attributable to a Part A funded incident or a Part C funded encounter or a Part B funded encounter, you need to have a rational way to allocate that charge across those providers. But really, you should not be charging, well, you can't charge anything to anyone below 100% of poverty. And when you start to get above 100% of poverty, you must charge something. And you must detect to see if across all those parts you've exceeded 10% of that client's annual income, regardless of what part paid for the underlying service. So as soon as you start to get into territory of exceeding the amount, the limitation on charges, it doesn't really matter. As long as that clinic agreed to take Ryan White funding, they have agreed to that limitation in charges for their clients. And that gets into tricky territory because they will say, oh, this is actually two clinics in one. I have a private pay clinic and I have a publicly funded clinic, and they aren't really the same. I think it is extremely doubtful that would survive an audit test.
Great, thank you. The next question is, what is considered non-targeted marketing promotions?
Right. Suppose you actually use Ryan White funding to just give people information about how HIV is transmitted and the importance of getting tested for HIV. That is not targeted enough on HIV care that it's an appropriate use of marketing funds. If you were marketing to say, our agency provides case management, and that will help you traverse the healthcare system and will help you deal with your adherence issues, please call us and we'll do an intake. That is targeted enough around a Ryan White funded service that would meet that litmus test. But if it's really just more of like a public information campaign, that's just kind of in generally about HIV and why it's important to you, that would be non-targeted. That's how we've always interpreted that. It should be targeted around a specific Ryan White funded service and the importance of an HIV positive person having access to that service.
Great. So, we've got a number of really good questions, so I think we may actually, I think we may actually go up to time, but folks have really, they're asking, and so I'm just going to keep reading them to you. The next question is, what if grant funds came into play after a clinic has been up and running for 5 to 10 years? Would program income still result?
So this is where you're gonna need to have a really good conversation with your program officer, and we have had them with ours, right? By the letter of the law, you need to make sure that all the program income for that whole clinic is being reported to you. I know that reaches a level of, I don't know, oddness. If, for instance, you're giving that clinic $5,000 to do some very small service, and it's a $5 million clinic, that clinic is going to be very reticent to tell you all of the program income that it is generating just because you gave them a $5,000 reward. What you need to focus on is that this comes from a grant-funded activity, all right? So it's an activity that would not be possible without your grant being there. It's a really good indicator that it's dependent on your grant. If it didn't exist before you gave it the grant, before you gave them a grant, that's like a prima facie. Obviously, this is a grant-dependent activity because it wasn't there before and it won't be there after. But suppose it was there before, but in a very small manner or a very underfunded manner and not really available to very many clients, had a waiting list, and then you came in and gave them a substantially new award, and now it's very dependent on your award. But really, what it comes down to is, how likely is it that that service would stop if you withdrew your award? That's probably going to give you a pretty good indication as to whether that is a grant-funded activity, grant-dependent activity on which you should be collecting program income. But this is worthy of a great conversation with your project officer, and HRSA also has some really great SEBA technical assistance providers that can help you think that through for your individual situations.
Okay, the next question is, what activities can be considered planning and evaluation activities on the subrecipient level?
Okay, I'm sorry, Lee, would you repeat that question? I'm trying to find it in the list here.
It says, what activities can be considered planning and evaluation activities on the subrecipient level?
That's an interesting question. Usually planning evaluation, those are usually things that the grantee does. Now, they could contract some of that out to a subgrantee, but it's pretty unusual for those to appear on a subgrantee award. Now, if you're a Part A, all of the costs of your planning council are subject to the administrative cap and would be considered planning type activities. Usually when you're working out your subrecipient budgets, if they have things like we're going to conduct a planning process to make sure that our agency, our clinic is doing things properly, that generally falls under their 10% limit on their administrative, right? And if they can convince you to go over that, you just have to make sure you don't do that for too many of your subrecipients so you go over 10% in aggregate on them. But you could technically, I suppose, have a subgrantee who says they want to do either a portion of the state's planning process or they want to do a localized planning process. You just have to make sure that that falls under the 10% aggregate cap.
Okay. The next question is, for client charges, do the limitations apply to charges for the uninsured only?
No. The short answer to that is no. Yeah.
Okay. Next question, it says, we currently use a Ryan White patient cap form for our HIV clients. Is it possible for you to send the most up-to-date client annual income and limit on charges figures? I want to be sure that our numbers are correct.
I believe those are actually in that document that the sample contract document that I posted. If I'm not mistaken, I included those on page 2. It comes right out of the HRSA requirement if I didn't include it in there. But we can certainly post that, can't we, Julio?
Yes, we will make that available as we post the materials from the webinar as well. So the next question, are the patient pay cap limits based on a calendar year or our fiscal year?
So those are based on the client's year, which makes it even more fun, doesn't it? So if you did an intake for a client on July 7th, it's really a year of that client's experience with you, right? Yeah. So that makes it pretty complicated if they have multiple years and multiple different, they have different clinics where they went to different years, they started one clinic differently than another. It is quite a burden both on clinics and on clients to track this because that's reality. Clients have complicated lives and they often go to multiple different agencies, but it really is their year, I guess is the way to say it. That's the way we've always interpreted it.
Mm-hmm. Okay, next question. You have presented a limit on charges. I understand this is for less than 100% of the federal poverty level. In the past, the 5%, 7%, and 10% limits were based on client payments. They could not pay more than those percentages. After they have paid the relevant percentage, all other services have no charge. Please advise.
Well, that's one way to state it, but I am just hesitant to go that way completely. They absolutely should not be charged anything if they're under 100% of poverty. So that's kind of implicit in what you said, but I just want to make that that's really clear in that, right? You could implement it the way you described and just say as their income increases, then their percentage increases, but I think it's more that you do an assessment at intake at what their annual income is, and then you determine at that point where the limitation should be for them, and then you impose that on them. I'm not quite familiar with the process that you've been using. That's not a process I'm familiar with.
So I have two back-to-back questions that are very similar regarding, is revenue generated from a 340B program by a Ryan White funded agency considered program income?
Mm-hmm. Well, that I'm not sure has been entirely clarified, but I'll tell you what my interpretation of that is. So this often occurs when you have a clinic that has a 340B pharmacy associated with it. Yes, I do believe that that is program income to the clinic. That 340B clinic only exists because it is affiliated with a Ryan White funded clinic, and as long as that's a Ryan White funded clinic, that's a Ryan White grant funded activity, that pharmacy should be demonstrating that that program income is being plowed back into either its own kind of operations or into the operations of that clinic. This actually came up during a site visit we had in Colorado, and that's the way it was explained to me.
Thank you. So the next question, you mentioned sub-grantees must have an HHS-approved indirect rate. Well, what about the 10% de minimis in the uniform guidance? Right.
So here's how that plays itself out. I'll just pretend I'm a HRSA site visitor, right? I'm one of your HRSA people, and they're looking at a budget that you had with a subgrantee. And on that budget it says, I want 9% indirect, all right? They should have an indirect cost rate. You can't call that indirect unless they have an indirect cost rate. They could say, I want 9% of my money to be used for the following purposes, like to pay for my executive director's salary, to pay for our medical record system, and so on. But if they don't have an indirect cost rate on hand, like approved by HHS, that word indirect should not be appearing on those budgets anywhere. Now, there is a de minimis, as you mentioned it, that if it's 10% or less, in the absence of a HHS-directed or indirect rate, you can give them 10%, but they shouldn't be calling it indirect. They should be calling it administrative. They should only be using that word indirect if they have an approved indirect rate with HHS. This also came up during a site visit, so we're very aware of that. Yeah. Does that make sense?
Great.
Yep.
Thank you. Where can I find the official language you referred to about payer of last resort? And what are the exceptions for IHS and VA?
So the official language is actually within the Ryan White Care Act. Oh, I should have put that citation. Next, are we going to post this again? Well, we'll be posting these slides. I will actually put the citation to the law itself on that slide, so you can find it. But that is the actual language that comes from the Ryan White Care Act itself.
So let's see. Unallowable Ryan White costs. It says mortgage is an unallowable cost under the emergency financial assistance line item. Clients sometimes need mortgage payment assistance.
Yes, they sure do. This is pretty unequivocal. They just say you cannot use this funding to make mortgage payments. And I do believe that the theory behind that is that you are adding to the value of that home. And when the client sells the home, they're going to get that value back. So you essentially made an indirect cash payment to a client. I know this is so tough for, you have clients who own their home and they're going to be made homeless because they're behind in their mortgage payments. But this is, unfortunately, I don't see much wiggle room in that rule.
Okay. The next question, do we need to have a separate dental sliding fee or can it be combined?
Right, so that sliding fee schedule applies to all services, right? So if it's a dental service, it could come under the same sliding fee schedule as your medical clinic. If they're affiliated with one another, it could be one for the entire clinic. But you need to make it very clear to the clients that applies to all the services they're getting under that umbrella. Otherwise, you'd be violating the public posting policy. So the idea was that the client coming through your dental practice who isn't in your outpatient care clinic shouldn't have to know that they need to go across town to your outpatient clinic to see that public notice. It should be posted in the clinic where it applies. But you can use the same one, and in fact, I think HRSA would prefer if you did.
Okay, next question. In HAB, the use of UOB requires a revised budget and a new NGA. My agency won't allow us to spend that money until the NGA arrives. Because HAB takes so long to approve the new budget and get the new NGA out, it is hard to spend UOB. What do we do?
My heart goes out to you. I don't know what else to tell you. Every grantee feels this could make the same statement that you said. This is really a problem. I know they do the best they can at HRSA to get those out quickly, but those wheels turn at the speed they're going to turn. The only advice that I've ever been able to do is to try and put things in your request that you could spend rapidly in 4 months or less. But I don't see any solution for that. I'm not a HRSA employee, so I can't explain it in any greater depth than that. However, I am sure waiting for my NGA right now, so I know what you're going through.
The next question is, if you have multiple funding that is a payer of last resort, then who pays first? Also, how do you verify on a site visit that payer of last resort is accurately applied?
Excellent question. Well, you will see that sometimes this puts you at odds with Medicaid, because there are times Medicaid tries to say that it's the payer of last resort, right? So you can get into a bit of a wrestling match with other funding sources, but the only way I can answer your question is, as the Ryan White grantee, it's your responsibility to assert your right to be the payer of last resort, and to insist on that as much as you possibly can. This is probably a conversation you need to have with your Medicaid authority But yes, I know the dilemma you're talking about, but generally, if you explain and cite the law the way that it's worded, you can reach a reasonable accommodation with Medicaid if it insists that you are the payer of last resort. I mean, you're the second in line, and they're the last payer of last resort. But yeah, it would have been nice if that had been worked out at the federal level, but unfortunately, we have to work that out at the state level. And then what was the second question again? Oh, how do you assure it when you go out on site visits?
Yeah.
This is a real challenge, I can tell you. You pretty much have to have someone going out and doing these kind of site visits that knows the ways that clinical and hospital billing systems work and draws a statistically significant sample of records for all the clients within that clinic, including all the ways in which those services were billed. And if you believe that that client was Medicaid eligible, you should see that Medicaid got billed for all of those services. It pretty much comes down to that simple. I know that this will mean that you will have to insist sometimes to see some records that they might not believe you have access to, which is why in your grant award or in your contract language, you need to be crystal clear about the fact that you reserve the right to conduct site visits and to inspect all billing and other records associated with that clinic. Otherwise, they're going to say, you didn't write in your contract, you don't get to see that, right? But about the only way you can do it is through a sampling technique where you ask to see client records and then you ask to see a history of all the ways in which those services rendered to that client were billed, and that you verify that if that client was Medicaid eligible, that the Medicaid got billed.
And I just wanted to throw in
Medicaid, but it'd be any third-party payer, yeah.
I just wanted to go ahead and throw in a plug for our Fiscal Health webinar next week that addresses program eligibility. That'll be on Tuesday, the 23rd at 2 p.m., and I think it'll probably touch upon that and some other questions that folks have brought up today as well. And so moving into the next question, the question is, can you go back over the client charges? Does it apply to all clients that come to our agency? We are an ART 28 FQHC and soon ART 31. Should we have different fee schedules?
Yeah, this is always a hard one to explain, particularly if you are a large FQHC and this is a tiny little HIV clinic within your large FQHC. I often get this question. You're seriously asking me to impose a different fee schedule for that small set of clients within my large institution than the rest of the institution. And the only answer I can have to that is, with my apologies, yes, that's exactly what I'm asking you to do. If those are clients of a Ryan White enabled activity, right, it's an activity that Ryan White participates in, and it would probably go away if the Ryan White money went away, then one of the conditions that your clinic has agreed to accept that Ryan White money is to have a separate fee schedule for that set of clients. And I will tell you, HRSA will absolutely find this as a finding on a site visit. They have done it many, many times. It's probably one of the most common findings that people have when they get their HRSA site visits, that you cannot use your regular fee schedule for these clients because these clients have a special limitation on charges. And I have explained to HRSA that in some cases has resulted in agencies being unwilling to accept our funds or returning their funds to us. So I know that HRSA is aware of that dilemma, but for the time being, that is the rule as it is written, and it is rigorously enforced.
Okay, we have about just a little over 10 minutes left, and I still have a number of questions, Bob. So let's see. The next question is, as it relates to payer of last resort, which is the priority to expend, Part A or Part B, et cetera?
Well, they're both payer of last resort. So they don't, okay, I should go back to the wording. So what it's saying is that if you have an alternative third-party payer, you must use that alternative third-party payer before you use any Ryan White money whatsoever, right? So Part A would not be saying on the payer of last resort over Part B. Now, they're going to have to say to their grantee, okay, we generally use our Part B money up before we use our Part A money, but that's not a pair of last resort issue. That's actually an allocation of the different awards to avoid duplication, because what your Part A and your Part B grantee are going to be worried about is you're using both of them to reimburse, right? Like you're what they call double dipping. You can't double dip A and B. But payer of last resort really has to do with funding sources outside of Ryan White, like Medicaid, third-party insurance of any kind, Medicare, all of that sort of stuff. That's where payer of last resort comes in. It doesn't come in to prioritizing your A and B funding one over the other.
All right, next question. Please describe reportable conditions to be conveyed to HRSA.
So, for instance, you have an A130 audit, 133 audit, and it says this clinic has been imposing a fee schedule that is not in compliance with the federal law. They charge more than they charge people under 100% of poverty. If that comes up in your A130 audit, that should be reported to HRSA. I'm just trying to think of the different ones I've seen. This agency did not have adequate documentation for its program income. So it was not appropriately reporting program income. That got detected by the A133 auditors. It gets conveyed to you. You need to convey that to HRSA. Chances are pretty good that if there's any finding in an A133 audit, you would be well advised to convey that upstream to HRSA. It may seem like a small dollar amount to you, but you're better off reporting it to them and then them finding out through other means that you didn't, and then saying, why did you not report a reportable condition? The new OMB circular actually is a little more directive about this, about what are considered reportable conditions, so I think we will be getting a lot more guidance on that from HRSA in the future. But at the moment, your best, safest policy is if you get an A133 audit or any other kind of an internal audit or any kind of a thing that tells you that one of your grantees, the sub-grantees, has done something that an auditor felt was inappropriate under federal law, just send it to your program officer and tell them you are working with that grantee to correct that condition.
And I think you touched on this, but someone just wanted to confirm or clarify, does the patient have to provide receipts for proof of cap costs?
Correct. So that's pretty clearly articulated in the policy notice, that it is not the responsibility of either the grantee on behalf of the entire state or each individual clinic to track what that client has experienced at other clinics. It is incumbent upon that client to come with that to you and say, here's my proof that you should stop charging me. Sometimes case managers help them assemble that material, because that's obviously pretty tough for some clients to do. But the good news is it is not your clinic's responsibility to call all the other clinics that that client has been seeing to see if you have to stop charging them.
All right, so someone had asked, okay, so they understand that the mortgage is disallowed, but what about rent?
Yeah, so rent is common. We often help people with rent. That's an absolutely allowable use. It's under the housing standards of care on the national level, and most Part A's and Part B's have that listed as well. The only restriction they have is that they generally want it to be time limited and reasonable and related to a medical need, right? So if you have been paying a client's rent for the past 3 years and they have a suppressed viral load and have no trouble getting to the doctor, you probably are going to get questioned on that. It's supposed to be time limited, amount limited, and clearly linked to them getting access to medical care.
Presently, the next question, presently we are not charging these clients any fees. Are we required to do so using the fee scale mentioned?
No. As long as you charge no client anything, you don't have to worry about this. So this is usually the case with things like case management agencies and food banks, and where they don't charge any client anything, then you're fine. But as soon as you charge a client anything, then the entire fee schedule comes on you. So that's probably a real thoughtful thing as we start to reach points where financials is starting to be tempting to charge clients for various types of things. Just remember, you're bringing down on yourself the limitations on charges.
Next question, and we're going to do a few more because we're coming up on time. So it says, does Ryan White cover the cost of the client deductible or co-insurance costs? That's typically the patient responsibility.
Right. So this is where your ADAP usually comes in, and if not your ADAP, it could be a Part A or Part B funded health insurance assistance program. So typically, like in our state, we would make that client eligible for our health insurance assistance program, and the health insurance assistance program would be paying the deductible for them, not the clinic itself. Right, so it's usually coming out of a different funding stream.
Okay, so the next question is, can Part B funding be spent by the subawardee on both Part B enrolled patients as well as Part B eligible patients?
That's an interesting distinction. So if I'm reading that, well, I'm afraid I don't know the difference between an enrolled patient and an eligible patient. That might be something that's kind of a distinction you make in your state or your clinic that I'm not familiar with. We often talk about people being certified or not certified, so meaning they met the eligibility criteria for the last 6 months or they haven't. But if it means that you're only permitted to spend Ryan White money on people who have met the eligibility criteria for Ryan White, so you cannot use Part B money for someone who has not met those eligibility criteria. I don't know what that means in terms of enrolled versus eligible. So I'm sorry, I can't answer that question.
And then, so the next question is there a citizenship requirement? Can funds be used for the undocumented?
Nowhere in the Ryan White Care Act does it say anything about a citizenship requirement. So as far as the federal government is concerned, that is not a requirement. And in fact, most states do provide some level of Ryan White services for people who are here, whether legally or not, and whether their documentation status is not a criteria. I do know that individual states may have state laws that dictate otherwise. And local agencies may have rules that dictate otherwise, so you can't say that the feds are going to force that on every particular provider or in every particular state. But as it relates to the program itself, to the federal program, no, citizenship is not a criteria.
Okay, so I have one clarification point, and then I'm going to do one last question because we're coming up on time. The clarification point is we have been told that clients above 100% FPL must be charged for any service they receive, including EFA. I believe I just heard you say that a client does not have to be charged if the service provider does not charge any clients for the service. Is that correct?
That is the way we have always imposed it here and the way that our program officers have always talked about it. I've never heard of anyone actually charging for emergency financial assistance. That's a new one on me. It's theoretically possible. I guess you're saying that your state or locale requires people to participate in their own care or in their own assistance, so maybe we'll pay $50 of that utility bill if you'll pay $5 of it. I'm not sure that would be considered a limitation. That's an interesting point. I've never heard that situation before. I do think it would be considered program income because it is a grant-funded activity, but I wonder if HRSA would consider that a charge. I think that's one you would have to take to your program officer. If that were happening in my state, I would consider it a charge, and I would say that it was subject to the limitation on charges.
All right, and for our final question, is 340B income considered program income if a pharmacy is housed in an SQHC that also receives Ryan White? In this case, the 340B access would be through SQHC status, not purely because the facility receives Ryan White grant funds.
So here's how I would interpret that. If a portion of that pharmacy's operation, and I would argue probably would have to be a significant portion of that pharmacy's operation, occurs because they have been designated an ADAP pharmacy, they're participating in the ADAP system, then I would say that that portion, at least, of their income is program income. That could be very tricky for that pharmacy to try and figure out how to allocate between those different things. because they probably also have a certain number of clients who are insured and so on. But as it pertains to the Ryan White eligible clients that are accessing that pharmacy and they're generating program income as a result, I do believe that that money would be considered program income and they would have to demonstrate that it was being used either to maintain the operation of that pharmacy or for the affiliated HIV clinic.
Okay. Thank you, everyone, for a very robust discussion this afternoon. You've generated some really terrific questions, and I know that there are folks that may think of others after this. Feel free to email any questions regarding this content or the Fiscal Health program to me. My email address is Julio, Julio, at healthhiv.org. I also wanted to state again that this webinar has been recorded and that we will be sending out a distribution link with the webinar archive as well as the materials that are associated with it, and it will be posted to the Target Center as well. I want to thank Bob again for doing this for us today and for taking the time to answer these questions and being a resource on this very important topic. And thank you all for your attention. Have a great day.
My pleasure, and again, thanks to everyone on the call.